Thank you for joining us today for our Ask the Allergist webinar, where your top food allergy and anaphylaxis questions are answered by a leading Canadian allergist. I am Jennifer Gertz, the Executive Director of Food Allergy Canada, and I have with me today Dr. Julia Upton. Before we get started, I wanted to note a few housekeeping items. First, all participants are muted so we can keep the audio clear for the webinar. Secondly, if you have any questions during the presentation, please submit them in the chat question box throughout the webinar. We will try to get them as many questions answered as we can. And thirdly, this webinar will be recorded and shared on foodallergycanada.ca afterwards. Please also note this webinar will not offer personalized medical advice about your specific circumstances. The information presented is also not a substitute for personalized medical advice from your healthcare professional. As always, please speak with your doctor before making any changes to your allergy management plan. Now I'd like to introduce Dr. Julia Upton. Dr. Upton is a Canadian allergist who is on staff at Toronto's SickKids Hospital in the Immunology and Allergy Department. She is an assistant professor in the Department of Paediatrics at the University of Toronto and is the section chair of Food Allergy and Anaphylaxis with the Canadian Society of Allergy and Clinical Immunology. Dr. Upton, over to you.
Great, thank you so much, Jennifer. It's a pleasure to be here today. And I hope that I can answer a lot of the questions that came in. Thank you, everyone, for your interest and your questions. So we're going to go through a bit of a definition of food allergy and the signs of food allergy. And then we'll do quite a lot of questions about allergy testing, as well as some on anaphylaxis, epinephrine, and a bit about the introduction of foods and what's going on with research. So I just want to start by saying that for this discussion, we're concentrating on a certain type of food reaction. People can have all sorts of different reactions to foods, such as lactose intolerance or discomfort from greasy foods. But today we are talking about immune-mediated food reactions, the blue box or circle. And so food allergy is an abnormal reaction caused by the immune system following consumption of a certain food. And there are many different types of immune-mediated food reactions. So some people have celiac disease, for example, which is an immune-mediated reaction to gluten, a component of wheat. And we're not talking about celiac disease in this webinar. Today we are concentrating on a specific type of immune-mediated reaction, which is caused by a specific arm of the immune system, and that's the IgE antibody part of the immune system. And IgE-mediated reactions are the ones that can give a person the risk of severe allergic reactions called anaphylaxis. So this is a picture of the signs and symptoms of anaphylaxis, and we can also use this picture to talk about the signs and symptoms of food allergy. So in the type of food allergy that I'm talking about, the IgE-mediated food allergy, when you eat the food, then you can have the symptoms of skin symptoms, so hives or swelling or itching. You can have respiratory symptoms like shortness of breath or wheezing. You can have reduced blood pressure, or you can have sudden gastrointestinal symptoms like feeling very crampy abdominal pain or vomiting. So we did get some questions about, can eczema be triggered by food allergies? So if there's no symptoms of food allergy, like the symptoms that I just mentioned on the previous slide, then we would typically advise to continue the food. Eczema itself does not usually need a change in the diet. It can be managed by moisturizing and medicated creams. Now, young children with eczema may also have a higher chance of food allergies, and so some kids with eczema do benefit from seeing an allergist to understand whether or not they do have other allergic problems such as food allergies or asthma or other allergic conditions. We got quite a few questions about the causes of food allergy, and certainly these could be many hours in and of themselves, but I did want, before we get into the main bulk of the questions, just touch base about the idea that the main causes of food allergy are thought to be the hygiene hypothesis. So this is an idea that in the westernized world, we are very, very clean, and we haven't been exposed to the same kinds of infections that we have throughout history. And so the immune system isn't learning properly. It's not being tested properly. It's not sort of seeing what the big problems are. And it also has a change in the microbiome, or the bugs that live with us. And all of these factors together seem to result in the immune system deciding to attack pollens and foods that it really should be leaving alone and tolerating. The other main cause thought to be of food allergy is the delayed introduction of foods. So certainly the evidence for the delayed introduction for peanut as a causative factor for peanut allergy is very high. And we will talk about that a little bit later in the presentation. The idea with that is that our bodies have been designed to know to ignore or tolerate foods that are introduced to it through the oral route or by eating, whereas if your body is seeing the food much later in life and maybe through the skin and other routes before it sees it through the mouth, then it becomes allergic. Again, these two ideas we wouldn't be able to do it justice in this session, but we will talk a little bit more about the delayed introduction. I also just want to mention IgE, because with all the questions about testing, it's important just to touch base on where is this IgE coming from. And so IgE is the allergy antibody. And in this picture, we can just see a schematic of what happens. And basically, an allergy-prone person encounters a potential allergen, maybe that's peanut or milk, and then the immune system thinks that it's a threat, and a cell starts making large amounts of an antibody called IgE. That IgE can travel in the blood, and it can land on other types of cells, including the mast cell. And then the next time the person encounters the food binds to that IgE on the mast cells, and the mast cells release the chemicals to fight that allergen. So, for example, histamine, platelet activating factor, other allergic chemicals that result in the symptoms of allergy. So when we're doing allergy tests, we're looking for that IgE. So the skin prick testing uses a drop of a sort of a purified version of the food, and we prick that with a sterile needle, and then we look after about 10-15 minutes and see whether or not we get a positive test. So a positive test is an area that becomes red and swollen. And so people asked about how can you determine the number that's assigned in the skin prick test, and how should it be interpreted? And so the skin prick tests are measured in millimeters. A lot of people use the largest diameter, but sometimes it's also an average. So usually your allergist can tell you which way they do it, but so long as it's consistent, then that's a helpful way to be able to compare numbers over time. You can also do blood tests to detect this IgE. So the skin tests and the blood tests are not perfect. So we know that with a negative test, most people with a negative test are not allergic. And I've shown that here by a big sign of the not allergy and only a little bit of allergy. So most people with a negative test to foods are not allergic to the food, meaning that when they eat the food, they do not have an allergic reaction. However, people with a positive test may be allergic or not. So they may have an allergy, but they also may not have an allergy. And this is one of the ways that interpretation of the skin test and blood test can be more challenging. We do know that the larger the test, the more likely it is that the person is allergic. So although a positive test does not tell you for sure whether somebody is allergic or not, a very large test is much more suggestive of the person being allergic. And so in this diagram, I've shown that with, on the left side with the small positive test, you can see it's sort of weighted equally. Are you allergic? Are you not? But then as the test gets bigger and bigger and bigger, it becomes much, much, much more likely that the person is truly allergic. And when I say allergic, I mean that when they eat the food, they have an allergic reaction. So why aren't these tests perfect? So I will say that most tests are not perfect. But in allergy, for example, we can have a positive allergy test because of cross-reaction. And a classic example people use are with tree pollens, which I'll show on the next slide. And we can have a negative test if we're missing something in the extract that we use for testing. So for those of you who've had allergy testing, you can see that usually we're using these purified extracts in little bottles, and they've been either heated or processed. And sometimes in that process, you can actually miss one of the relevant bits of the allergen. In general, though, being allergic with a negative test is not very common. It's more that you can have positive tests and yet not react to the food when you eat it. So just to show a bit more of this cross-reactivity, so people with tree allergy or tree pollen allergy, meaning that they have allergic rhinitis symptoms or seasonal allergy symptoms in the spring, can have positive tests to tree nuts, but not actually react to the food when they eat it. And this can be difficult to determine the difference sometimes. So we've got a lot of questions about the accuracy. And so when we talk about accuracy, how accurate are the skin prick and blood tests? So they are accurate at detecting is the IgE there or not. But the issue is that people can have this IgE antibody on the cells or in the blood and not actually be allergic. And so what is more accurate, the blood test or the skin prick test to diagnose peanut allergy? So, again, if we think of accuracy as can you detect the IgE, so the skin tests are better at finding IgE because they find it even when it's only on the cells, like we showed in the picture earlier. But because it finds the IgE even better than the blood test, the skin test can also overdiagnose allergy more than the blood test, because not everybody that has the IgE is actually allergic. So is a skin test on its own 100% accurate? And hopefully I'm showing that the answer there is no. However, the larger the skin test, the more likely it is that the person is allergic. A lot of people asked about what age can food allergies be diagnosed, and they can be diagnosed at any age. There's no lower limit. A lot of people, I think, have heard about that we don't typically do pollen allergy testing or seasonal allergy testing in very young kids, less than about 2 or 3 or 4. But food allergy, you can test anytime. People asked, is it true that a worsening skin prick test, meaning a larger wheal, does not correlate with a worse reaction? And that's correct, that the larger the skin prick test, it's more likely that someone is allergic, but the size does not consistently correlate with the actual severity of the reaction. So it's more about the chances that we think you're allergic, not how severe the allergy is. So maybe you could think of it as, what are the chances it will rain tomorrow rather than how much rain will there be. People asked about when should you have a blood test versus a skin test, and asked another way, when is the blood work warranted to help confirm a suspected allergy? So blood tests can be used instead of skin prick tests or in addition to the skin prick tests. And in general, we use them if we need more information to make decisions. And so the blood test can give a number, which can help allergists decide if they want to offer an oral food challenge, for example. We can also get a number from the skin prick test. But sometimes people like to have the number from the blood test to be able to compare it to some of the published numbers. We can also use blood tests to find out if somebody is eligible for a study, for example. It gives a number that you can follow over time. There's also times where we would use a blood test where we cannot use a skin prick test, for example, when somebody is on medications that interfere with the skin prick testing, such as antihistamines, or if somebody has very extensive eczema, for example, and there isn't a clear patch of skin to be able to do skin prick testing. So that would be another reason why. So what do these allergy tests really mean? And I'm hoping to get across that there's no real number that's absolutely definitive. It is a piece of information that we use as part of a total assessment. So are they not accurate? And again, we're talking about they give a risk of allergy. They don't diagnose allergy in and of themselves, and they're a tool. So I like thinking of these scales because in terms of how do we actually use the test, what we're trying to do is try to think about how likely do we think that a child or an adult is allergic or still allergic, for example. Or do these tests change what we think after listening to the story of what happened when they were exposed to the food? And can we get more information by offering a food challenge? So these are some of the thoughts that we think about. And I'll give a few examples later of putting all of this information together. Some people asked about, is it possible to do molecular or component allergy testing in Canada? So we'll just touch base on that briefly. It is certainly available in Ontario. It is not covered by OHIP. But a lot of private insurance companies will cover it. And if you're seen by an allergist in a hospital setting, sometimes that hospital covers the testing. But certainly it is available in Ontario. I'm not 100% sure of the availability across the country. But molecular allergy tests are also called component allergy tests. And just to give an idea of what these are like, so most allergy tests use the whole food. So you can imagine if we're testing for milk, for example, then we have a milk extract, which is just basically a purified version of complete milk. But we can also use components of the food. And I've always liked this poem to get across the idea of components. So we're all familiar with the Little Miss Muffet nursery rhyme, and so she's eating her curds and whey, and so milk is made up of curds and whey, and so within the curds is predominantly casein, which is a component of milk, and within the whey are a whole bunch of other milk-related proteins. So we can imagine that you can actually, rather than testing the entire milk or the entire peanut or tree nuts or other things, you can actually test components of those foods, and in some settings actually testing those pieces have been able to be more accurate in terms of predicting whether somebody will actually react to the food when it's fed to them. So back to our trees, an example of component testing where it's used is that it can help to tell the difference between tree pollen allergy and true tree nut allergy, meaning it can help tell the difference between somebody who has a positive skin prick test just because they're let's say hazelnut, just because they're allergic to tree pollen, versus somebody who will actually have an allergic reaction when they eat hazelnuts. So let's maybe put a few of these things together. So, when an allergist is seeing an adult or a child, we're often trying to figure out, are you allergic or not allergic to that food? And so some of the things we might be thinking about is how long ago was the reaction, how much was eaten, what happened when you ate it, was the food okay in the past, and could there be another reason for the symptoms that the person experienced? And then the testing is really only one part of this assessment. And let's just go through maybe a couple of examples, and you can also decide what you think. So for example, if I tell you about someone who a month ago had a chocolate that may contain peanut, and they had hives the very next day, and at that time they actually had some viral symptoms. They also are known to have seasonal allergies. And when you ask about do they normally eat peanuts, and actually they normally eat handfuls of peanuts routinely. So this whole thing was a bit odd. And the skin prick testing, which I must admit in this situation not everyone would do, but just for the sake of discussion, let's say that the skin prick testing was 4 millimeters. So when you hear the story in this situation, it really doesn't sound like the person is allergic. They have a very clear history of being able to eat peanuts without any issue, and they have really another reason for the hives that they had, and the hives are quite removed from when they ate it. Let's compare that with this story, where again, a month ago, a person who had actually never eaten peanuts before had a bite of a peanut-containing sauce. They were completely well otherwise until then. They're not on any medications. They have no seasonal allergies. And yet, within 10 minutes of eating this one bite of peanut sauce, they had hives and vomiting and wheezing, and actually called an ambulance and was treated with epinephrine and went to the emergency department. This person also has a 4 millimeter skin prick test. So you can see in these examples that the testing is exactly the same, but the first person is very likely to be not allergic, and the second person is very likely to be allergic. So in this one that I have up on the screen now, this 4 millimeter skin prick test really is confirming what the doctor thought on the history. This person sounds allergic, and the skin prick test confirms it. Whereas in the first one, when you hear the story, you're not really convinced that they're allergic, and then maybe there's another reason for that small positive skin prick test. We'll just do another one where a month ago, a person had a bite of a peanut sauce. They were well otherwise, no meds, no seasonal allergies. They had hives within 15 minutes, and this person has never eaten peanut either. And here they have a huge skin prick test, 20 millimeters. So in this example, the reaction was quite mild, but we really have no other reason for it. The person has no history of tolerating peanut, and the testing is very large. So In this case, many allergists would also make the diagnosis of peanut allergy. So I hope those just give a little bit of an idea of some of the factors that we consider when we're trying to decide, do we think somebody is allergic or not? So when we really did get a lot of questions about allergy testing. So having given that background, people ask about, how do you interpret the numbers? And I would suggest to you that it really depends on what you want to know. So do you want to know if the test is so high that you believe it's confirmatory or that the person is allergic? Or are you looking for, is the test low enough that you think the person might not be allergic or maybe not allergic anymore? And so there are published numbers which can help. These are predominantly for milk, egg, peanuts, and tree nuts. And thinking about that assessment that we talked about, where we're including the history and what happened, the numbers are actually influenced by age and has the person had an allergic reaction to the food before. So the number that in some populations can predict, for example, a 50-50 chance of being allergic to peanut really differs depending on the age of the child and whether or not they've eaten it before. So again, really what we're trying to do is just come up with a risk or a chance that we think that somebody's allergic. Sometimes the whole story together is so convincing that we're comfortable making the diagnosis. Other times we think, oh, you know what, I'm really not sure. And so people asked about, well, what about some of the other foods? What about sesame, sunflower? People asked about wheat, lots of different foods. So what is the value or the number that indicates the child likely has an allergy? So for foods that have been less commonly reported in the literature, we rely even more on the history because there may not be enough patients reported to use the numbers effectively. And by that, I mean, there may not be what we call the decision points. So for some foods, we have numbers that are suggestive of a 50-50 chance and numbers that are suggestive of a greater than 95% chance. But we don't have those numbers for every food. And so then we have to make a decision based on the history and with the family, where do we think this is, and how important is this food, and do we need to do further testing to help figure out if this person is really allergic or not? So we'll talk about other things that we can do in a minute. I just wanted to point out the actual messaging that is on the IgE tests. So this is pulled right from an IgE test from LifeLabs. And you can see that right on the test results, it says caution should be exercised when interpreting the clinical significance of specific IgE tests. Both positive and negative tests should always be interpreted within the context of the patient's allergy history. The concentration of food-specific IgE does not correlate directly with the severity of symptoms. Positive tests may be found in clinically asymptomatic individuals. And then they also add in there that a negative test on its own does not rule out allergy, which is also true, although people with negative tests having an allergy is less of an issue than people with positive tests not having an allergy in terms of statistics. We got questions about what are the differences between IgA versus IgG versus IgE testing. So before we leave this focus on testing, I do want to touch base about these different tests. So testing for IgA and IgG are not indicated for the type of food allergy that we've been talking about. The IgA testing is most commonly used for celiac disease. And we'll talk a little bit more about IgG testing. So there's no body of research that supports the use of blood IgG4 testing to diagnose allergic reactions to food or to predict future allergic reactions. So I have taken a few clippings from articles or from newspaper or I think it's the CBC down there, just about this being a pretty widely held opinion. So you can see way back in 2008, the European Academy of Allergy wrote about the IgG4 testing being not recommended as a diagnostic tool. This has also been written about in Canada in the Complementary Medicine Journal, as well as at the CSACI, which is the Canadian Society of Allergy and Clinical Immunology. And then very recently, there was a Marketplace episode about this, about no validity to these IgG4 tests. So hopefully those clippings there can help you read more about it if you're interested. People also asked about other unproven tests. And so, for example, Vega tests, electrical tests. Sorry about the duplicate test there. So one page that I think has been useful is there's this kidswithfoodallergies.org page, which talks about the unproven methods for food allergy testing. And really the only current clinical way to diagnose food allergy is with a careful history, the IgE antibody-based detection, so either by the skin prick testing or the blood testing, and an oral food challenge if needed. And this will be on Food Allergy Canada's website if you're interested in some of these references and haven't had a chance to get them. So people have asked about outgrowing food allergy. So can you outgrow an allergy even if you've had an anaphylactic reaction? And certainly the answer is yes. Anyone that has a food allergy has the potential to have an anaphylactic reaction. And so the fact that you've had one doesn't mean that you'll never outgrow the food allergy. People wondered how often should we test for allergies. So if an allergy has been confirmed or is very likely, like some of those situations that I showed earlier, then we would often recommend retesting about once a year or even every 6 months if very young. What we're doing there is looking to see, well, we're taking a history again to hear, has there been an accidental exposure? Has there been a reaction? But then also, what is that testing doing? Because if the testing is getting much smaller and there's no reason to believe that that you're still allergic, so you haven't had a recent reaction, then maybe this is on the trend to outgrowing. So that's how we're using those. People ask quite a bit about cross-reactivity. So, if I'm peanut allergic, do I avoid tree nuts? If I'm peanut allergic, do I avoid legumes? If I'm seed allergic, do I avoid all seeds? So in general, we're really trying to minimize the diagnosis of food allergy simply based on other foods. And so I would really recommend that you discuss with your allergist cross-reactivity and how to handle this, because it is a diagnostic challenge that you can end up with positive tests to similar foods, even though you may or may not react to that actual food when you eat it. And so this really does need an approach that works for you and your allergist to try to sort through these cross-reactivities. And somebody asked about, they had 2 different skin prick tests that have shown conflicting results. So the first was negative, and then 6 months later was positive. And how would we explain that? And so, ideally the almonds would have been introduced after that negative test because there's really no benefit to delayed introduction. As time goes on without introduction, we know that for peanut, the risk of allergy increases. And so a possibility here could have been that, that the person became allergic in that period of time. They could have developed a cross-reactive test due to tree pollen allergy, or it could just be a straight false positive test. And so, you would need to discuss that further with your allergist. So because the testing that we have in terms of the skin prick testing, the blood testing, is not perfect, and it's not always clear from the history and tests if someone is allergic or not, we do have another tool, and that's the oral food challenge. So that's where the person eats the food under medical supervision to find out if they are allergic or not. So I'll give a picture here of an oral food challenge example to almonds. So here you can see it's in 5 steps, going from a very small amount up to about 6 nuts at the end, giving a total of about 8.5 or so nuts. And so the total amount would be based on a serving size, and it would be appropriate for age. And, the person would eat a small amount, wait about 20 minutes. They would be checked for signs of allergy. If there's no signs of allergy, then they would eat the next step. Often it's in 5 to 8 steps. This one I'm showing here is 5. And it takes a few, it can take about an hour or an hour and a half to eat the serving. And then they wait for an hour or 2 after finishing the serving. So people asked about when should parents be recommended to bring their child to an allergist to perform a supervised oral food challenge. So usually in what we call the clinical setting, or in an outpatient setting, or when you're being followed by your allergist in the office, this is when somebody thinks you're not allergic anymore. So clinics and hospitals differ in terms of the risk that they're willing to offer an oral food challenge at, but typically it's at 50% risk of allergy or much less. And again, how do we come to that percent decision? I mean, it's a little bit arbitrary, but we're using the history, the age, the reaction, and the testing to try to come to what we believe are the chances that somebody will actually have a true allergic reaction when they eat the food. In studies, however, the oral food challenge is actually used to confirm the food allergy. So in order to begin many food allergy studies, we want to make sure that we truly have allergic people, because otherwise it wouldn't really be fair to go through the procedures and protocols in that study if you're not actually allergic. So a lot of the food allergy studies actually do start with confirming the food allergy with an oral food challenge. So at what age should oral food challenges start, and how often should they occur? So there's no lower age limit for oral food challenges. And again, the decision is based on risk. So, if a person has a very convincing reaction a year ago, and the testing this year is bigger, and they had an accidental exposure with some symptoms, the chances that that person's going to pass a food challenge are really not very high. And so it probably wouldn't be offered in that setting. Whereas if it's been years since somebody had any reactions and the testing has been getting smaller, then it may be worth offering that challenge. So again, it comes down to risk. So let's say you've had a successful food challenge. Is it possible to develop that same allergy again later in life if you're not exposed? And the answer is yes. The oral food challenge is intended to allow the reintroduction of the food. And we know not everybody wants to eat the food, but the issue is that this test really doesn't, it's not as predictive if you then don't go and eat the food for years and years. You can imagine if you get any other kind of medical test done today, if you get a heart test or a lung test, you wouldn't expect that test to be valid 5 years from now. So if the person doesn't eat the food for years, then really the oral food challenge has less ability to predict if you're actually allergic. So we do recommend that if you pass an oral food challenge, meaning you ate the food and you did not have an allergic reaction, that you then introduce the food into the diet. In a clinical setting, do allergists trial food challenges with anaphylactic allergies? And so again, allergists make a decision about risk, and all food allergies are potentially anaphylactic, and they're unlikely to offer an oral food challenge to someone who sounds clearly allergic with a recent severe reaction, unless, of course, it's in a study. So just to summarize, we offer oral food challenges if we want to be certain of an allergy, for example, to begin a study, or if we think that there's a chance that the person is not allergic. And then what chance that is will really depend on the setup of the office or the hospital. So are oral food challenges more accurate than skin tests? And the answer is yes. The food challenge is the truth. Can you eat it or not? I mean, when we're talking about food allergy, we're talking about, do you have an allergic reaction when you eat the food? And so by eating the food in a medically supervised setting, we know whether or not you have an allergic reaction to it. And so the food challenge is more accurate than skin tests or even the blood test. And the food challenges are actually the gold standard for diagnosing allergy. And if we want to be even more particular, we do what we call a double-blinded, placebo-controlled oral food challenge, meaning that you are fed the person is fed the food or not the food, and they don't know which one it is. And that just that's in order to help people deal with the anxiety of the situation. It can be very stressful to undergo a food challenge for some people, and so there are settings, like again in studies, for example, where we actually do a one day where you get the food and one day where you do not get the food, and you don't know which one, and the doctor doesn't know which one, just to make absolutely sure that if there's a reaction or symptoms, that it's because of the food and not because of the sort of stressful setting or other allergic medical issues that you might have. But in general, the oral food challenge is the truth, the gold standard. Can you eat it without a reaction? Or when you eat it, do you have a reaction? So on the day of the oral food challenge, we need people to be healthy. If you have asthma, it has to be really well controlled. We usually ask people not to take antihistamines because we want to be able to see the very first signs of allergic reaction if it happens. And we aim for this oral food challenge to be definitive. If you're going to go through this, it often involves taking time off school or off work. We want we want to find the answer. So we want to know, is the person allergic? But at the same time, we really want to balance safety. And that's why we do those small increasing amounts. And that's why the person is assessed after each step. And we're really trying to stop the oral food challenge at the smallest amount of food that can give a diagnostic reaction. So often when I give similar talks, people ask, well, why doesn't everybody just get an oral food challenge? You know, if there are uncertainties left in the test, shouldn't everybody get an oral food challenge? But the issue is that there's a risk to an oral food challenge, and that risk is anaphylaxis. So these are very time consuming, and they have this risk of reaction. And so that's where you know, the physician tries to decide who are we not certain about in terms of diagnosing them as allergic based on the history and the skin prick testing or the blood testing, and then tries to offer the oral food challenges to people that they think they can delabel. So anaphylaxis is a severe allergic reaction, and it usually involves two systems. So we've talked a bit about how you can have skin symptoms, respiratory symptoms, gastrointestinal symptoms, or cardiovascular symptoms. And so people ask quite a lot about exposure questions. So can nut residue on a finger that bites the eye of a person with anaphylaxis cause a reaction? And the answer is yes, it can. Mucous membrane contact can cause an allergic reaction, although typically it's ingestion that causes an allergic reaction. And can airborne exposure cause anaphylaxis? So generally, no. There's a very interesting study from years ago where a jar of peanut butter was put in a glass box, and they sampled the air around the peanut butter, and they found that there was no protein, so no peanut proteins that could cause an allergic reaction were found in the smell of the peanut butter. On the other hand, there are rare reports of reactions to the air around boiling food, such as shellfish. And so it is possible for the proteins to become airborne, but it's certainly less common than the usual way of an exposure, which is through ingestion. There can also be food, dust, or particles in the air. You can imagine if you're allergic to flour in a bakery, then that can cause allergy. Or back in the days where there were restaurants with peanuts and peanut shells all over the ground, you know, that you can kick up that dust. So it is possible, but in typical settings, it is really it's ingestion that is the main route of exposure that can be controlled and avoided, and these other routes are far less likely. People asked about kissing. So there are rare reports of kissing. It is known that allergens can be detected for hours after eating the food, you know, in the mouth and in saliva. And so we do actually have a bit of guidance on Food Allergy Canada about kissing and food allergies. Again, it is quite rare. People asked about may contain. So do we advise for people to avoid may contain? So the amounts allowed in may contain can actually vary quite widely, and we usually do advise to avoid may contain products. One of the questions was about somebody who has tree nut allergy, who it can eat some types of tree nuts, but then finds it very difficult because any of the tree nut products that they find are labeled may contain other tree nuts. And so one of the recommendations we give is that tree nuts can be purchased in their shells, for example. I just want to just ask Jennifer Gertz to add in here, because of their advocacy work with Food Allergy Canada and Health Canada. They know a lot about may contain. Jennifer?
Great. Thank you, Dr. Upton. So just a couple of things. First off, Health Canada is the regulator of labeling. When it comes to may contain, or what we call precautionary labeling, there is no regulation that requires it, and there's no regulation that prohibits it. It's up to the individual manufacturers on whether they want to use that statement. However, Health Canada does give guidance to manufacturers to say that there should be a possibility of some risk if they're going to use a may contain statement. Our advice to the audience is that if you have specific questions about a precautionary label or a may contain label, is that you call the manufacturer for further information.
Great. Thank you so much, Jennifer. So we were also asked about oils. So it is true that most individuals with allergies can safely eat the highly refined oil of their allergens, such as peanut oil. However, the gourmet oils like cold pressed, expelled, or extruded peanut oil can actually contain enough protein to cause an allergic reaction. And so this gets into how do you know exactly which oil you have? And my experience has been that many people that are allergic to, for example, peanut aren't really keen on the taste of peanut oil because it tastes and smells the same. So I mean that's it is true that that very highly refined oils do not typically contain the allergen. So we just to talk a bit more about anaphylaxis and the symptoms as we move into EpiPen and epinephrine autoinjectors. We were asked about, is anaphylaxis instantaneous? And so anaphylaxis usually occurs within minutes to hours of exposure to the allergen. When we do an oral food challenge, for example, we watch people for at least an hour afterwards. Some studies, we actually watch them for longer because in the studies we're doing food challenges that we know the person will react. And if the person does react, then we tend to watch them for 4 to 6 hours afterwards because of the chances of there being what they call a biphasic reaction or the reaction coming back afterwards. But in general, the symptoms of anaphylaxis usually occur within minutes to hours of exposure. We had quite a few questions about can the reaction worsen with each exposure. So for example, does anaphylaxis get worse with each exposure to peanut, or my child only had one anaphylactic reaction to cashews, will the subsequent reactions be more severe? So severity is very hard to predict, and you can imagine from what we've chatted about already that there can be many variables when you have an accidental exposure that make it difficult to know exactly how severe things will be. You can imagine that one time you might have a very tiny exposure, another time you might actually take a bite of a food that contains a large amount of the allergen because of an accident. You may have a full stomach, you may have an empty stomach, you may exercise just afterwards. If you have other allergic conditions like asthma, perhaps that's better or worse controlled at the time of the accidental exposure. You can be sick, you can have taken medications, you can imagine we can go on and on and on about the variability in not only how much did you get exposed to, but also what's the state of your body that day. And so we don't usually say that it's for sure that a reaction will be worse the next time. Anyone that has a food allergy has a risk of anaphylaxis, and that's why we try to be prepared for that possibility. But in general, we don't say that it definitely will worsen. So someone asked, will anaphylaxis wake my toddler up, or could he die in his sleep? And so I have to say this question caught my breath when I read it because it highlights the fear and worry that parents of an allergic child experience. Fatal anaphylaxis is very rare, and it's even more rare in the preschool age group. It's extremely unlikely that this would happen. And again, usually anaphylaxis will happen after exposure, within minutes to hours. And so, typically you would have good observation of the child in that time, but it's really very unlikely. I think overall we try to be, prepared and try not to, worry too much about the extremely unlikely events. So the next question is in the same sort of idea that you hear incidents of accidental exposures to peanuts and that the child or teen has died even using epinephrine. Does the epinephrine autoinjector work? So the best treatment for an anaphylactic reaction is epinephrine because it widens the tight airways, it tightens the wide blood vessels. And the main risk factors for fatal outcomes are uncontrolled asthma and the delayed use of epinephrine. So Basically, the earlier you give it, the better it works. And there are cases like this, you are right, and thankfully they really are extraordinarily rare. So let's just talk about when do we give epinephrine. So there's a nice poster called Think Fast that just reminds us of the symptoms of allergic reactions and then to give epinephrine. So we definitely give epinephrine if there's two systems involved. Many people ask, do we give epi if there's only one system? And certainly if the system is the cardiovascular system, so meaning that you feel faint or dizzy, or if you know you have low blood pressure, if there's a collapse, then yes, certainly you would give epinephrine for that. We also tend to advise, if there's one severe symptom. So, it certainly wouldn't be wrong to give it for extensive hives or for chest tightness, airway tightness, if you have known asthma and an allergic reaction. So in general, we say two systems for sure. One, if it's cardiovascular, definitely, and many people advise that even with one system, it's not unreasonable to give it. The problem with anaphylaxis is it's difficult to know how the reaction will progress. So many people do advise that if you're concerned, questioning, should you give it, then you may as well just give it. There's really no contraindication to epinephrine in an allergic reaction, and the earlier you give it, the better it works. And so it's one of the toughest questions in allergy, I think, because it is hard to give the exact advice for when to give it. It's very clear when there's two systems involved, but other than that, it becomes more of a judgment call. So advice about your specific situation can be given by your physician in an anaphylaxis action plan. And so I do advise that you speak to your doctor about exactly when to give epi for your particular situation. And it's also very important to go to the hospital, if they're after giving epi, if there's an allergic reaction or anaphylaxis. So people asked about how many times can you give the epinephrine autoinjector. So you're allowed to repeat the autoinjector after 5 minutes, and you can continue to do that, as long as it's necessary. People asked about, are there negative effects of giving an EpiPen Junior to a 20-pound, and I just put in the kilos there, a 9-kilo child. So this has been discussed in the medical literature a bit, that the risk balance favors giving epinephrine even when they're less than the 15 kilos, which is labeled on the Junior device. And that's because it's so difficult for somebody that's not really used to handling needles and syringes to draw up the exact amount. And it really would create a barrier to giving the epinephrine that is, on balance, it is better to give this slightly too much epi, but at least you know exactly how much it is, than trying to fumble with drawing it up or not giving it at all. So certainly the advice is that we do give the Junior devices even to kids that are a little bit less than the weight. So this is similar to the other question, what if epinephrine doesn't seem to work? So epinephrine is most effective when used right away. And as in the poster, if we're concerned about an allergic reaction, then 911 will have been called and epi will be repeated. And for those people who also have asthma, then they can also use their inhaler. But so if the epi doesn't seem to work right away, certainly you can repeat after 5 minutes, and EMS ideally will have been called. So people asked about what besides epinephrine is the best medication to use during an allergic reaction. So epinephrine, again, is the medication to use during anaphylaxis. Additional medications can be used, such as inhalers like salbutamol, or antihistamines can be used after the epi. They do not take place of the epinephrine. And so more specifically, when should antihistamines be used during an allergic reaction, and are some better than others? So again, in anaphylaxis, use epinephrine. The antihistamines are really only supportive. They can be used to reduce itch, for example, or comfort measures. There's no reason to rush to give an antihistamine. The antihistamine doesn't have the time of onset to help with the breathing or cardiovascular symptoms. If you are going to use an antihistamine, then we do recommend non-sedating antihistamines because then they don't get all of the effects of the sedating ones, which can make people very, very sleepy, and in young children can actually sometimes make them act in a very unusual way. So we were specifically asked how to explain to parents that in schools the treatment for a student with anaphylaxis is EpiPen, not Benadryl like they use at home. So again, Benadryl or diphenhydramine is not the treatment for anaphylaxis, whether it's at home or at school. And again, we want to think of antihistamines as a comfort measure for itch. They really do not act fast enough for the cardiovascular or respiratory symptoms of anaphylaxis. So a lot of these questions may be helped by having an anaphylaxis action plan. And so I've put here a link on Food Allergy Canada to an anaphylaxis action plan. And one of the nice things about this particular one is it notes whether or not the person is, has asthma, and reminding people that if somebody with asthma is thought to be having an allergic reaction, it's important to give the epi and not just the inhalers. People asked about would regular antihistamines improve or worsen food allergy, and this really has not been studied. It's a very interesting idea, the idea that, if we always say the antihistamines don't work fast enough, well, what if they're on board all the time? So I applaud the question, but it has not been studied. And would regular accidental exposure to a food allergen make the allergy more or less severe? I wanted to just touch base about this question because I'm unclear about regular accidental exposure at school. So if a child is allergic, hopefully there's a clear plan discussed with the school of what the child is allowed or not. So, I would like to think there wouldn't be regular accidental exposure. So the epinephrine autoinjectors, we just want, as you know, there has been a significant shortage, and people are asking about, is there still a shortage? And again, I'd like to bring in Jennifer Gertz to mention this because of all the work Food Allergy Canada has done with the government.
Great, thanks, Dr. Upton. So the situation as it stands today is EpiPen is still listed as being on preventative allocation. What that means is that the company who manufactures it is controlling the amount of product that actually gets out to pharmacies. So what you might be experiencing at pharmacy level is that the pharmacist might be limiting the number of devices that you can receive. So that situation has there's no end date in sight on that yet. But what we will remind you is that there is a temporary supply in place of a product called Aviq that's available. So if you're not able to get your full prescription needs met with the EpiPen product, you should be asking your allergist and your pharmacist to give you a prescription of Aviq. That's the former Allergic product. Okay, Julia, back to you.
Great, thank you. So we had some questions about the introduction of foods, and so delaying foods does not prevent allergy, and it was clearly shown in a large study called the LEAP study that eating peanut between 4 and 11 months and then keeping peanut in the diet very much reduced the number of peanut allergic kids at age 5. So some babies are considered higher risk for having an allergic reaction and may warrant a medically supervised approach. And so please do see your doctor if your baby has eczema or an egg allergy for more specific advice about introduction of foods. People asked about what are the symptoms of an allergic reaction in an infant and what should they look for. So mild symptoms can include a new rash or some hives, and then more severe symptoms can include, the classic allergic symptoms like lip swelling, vomiting, widespread hives, face or tongue swelling, breathing problems, repetitive coughing, changes in the skin, and then symptoms of cardiovascular involvement in an infant like sudden tiredness or lethargy or seeming limp. And if you were introducing foods and you had any concerns about your infant's response, then please do seek immediate medical attention. We do have an early introduction webinar on Food Allergy Canada, and we also have quite an extensive frequently asked questions about early introduction. And then also the the North American guidelines, or the NIAID guidelines for early introduction of peanut, are also linked through Food Allergy Canada's website. And just, in the last little bit, we'll talk a bit about the research. So in general, the research direction in food allergy is based on testing improvements. So we want more accurate tests to increase the certainty of allergic diagnoses. We want to be able to tell people when they have outgrown the allergy. We want to be able to tell people if we really believe they're allergic. And so this is an area of extensive research all across the world, trying to look at tests such as the basophil activation test, looking at the best use of component testing, all of these kinds of things to try to increase the diagnostic accuracy of testing. In terms of treatment, there are a number of avenues of food allergy treatment being explored currently. So there's a medications alone approach. So the idea here is that you lessen the allergic response. So there's a medication called omalizumab that's already approved for hives and for asthma. And it's an anti-IgE medication. And it actually recently received breakthrough designation for the study in food allergy. And so, we'll see what happens in the future with that. And then there may be blocking other pathways than IgE to lessen the severity that are being investigated. So this would be a medication approach. Then there's an immunotherapy approach, and the aim there is to actually change the immune system's response to the food. And so you can try to do that with the oral route, through the skin, or under the tongue. And this is a food-based approach where you need to ingest the actual food or be exposed to the actual food if it's under the skin or under the tongue, and then keep it around, keep the immune system seeing it. And if there's multiple food allergies, then you need to perform OIT or immunotherapy to all of those foods. So that's an approach that's being investigated. There's also modified food approach. So there are companies that are looking at changing the way that peanut looks to the immune system so that it can actually be given as an injection, where they're hoping that that will help to teach the immune system not to fight that food anymore, but also it's modified enough that hopefully they won't have significant allergic reactions during the injection. So that's at a very early stage. Then there's approaches of using medications and immunotherapy together. So you can imagine if you have a medication that can reduce the allergic response, maybe you could do that with immunotherapy and make immunotherapy more tolerable. And so trials are going on using that approach as well. And for more information, we actually just did a webinar on oral immunotherapy. There's also a lot of press releases about food allergy treatment that you may want to look up. And then active trials of your food of interest can be looked up at clinicaltrials.gov. And you can also, of course, ask your allergist. So in summary, the allergy tests really only tell us a risk of allergy. The whole picture is important. The oral food challenge is the best test we have, but it carries a risk of allergic reaction, and it's time-consuming and expensive. Epinephrine is the first-line treatment of anaphylaxis. The early introduction of foods, specifically peanut, has been shown to be the best prevention that we have currently. And then in research, there's great interest in more accurate tests, and then treatments in the future may include medication approaches, immunotherapy approaches, or immunotherapy with medication-based approaches. So thank you very much.
Well, thank you very much, Dr. Upton. That was a lot of questions that you covered in your presentation and a lot of insight. We will, for those of you where we weren't able to address your question, we will do our very best to get back to you individually. We'd also like to take a moment to thank our sponsors for our ongoing webinar series, Pfizer Canada, the Sean Delaney Memorial Golf Classic, the Walter and Maria Schroeder Foundation, and the Peanut Bureau of Canada. Please also consider donating to Food Allergy Canada. We are a nationally registered charity, and we rely on your donations in order to provide services to support the food allergy community, like these ongoing informative and educational webinars. We would be grateful for your support. Please visit foodallergycanada.ca/donate to learn more about the impact your donations will make. Thank you for your participation in this webinar. We hope you found the information helpful and useful. There will be a short survey that you will receive through GoToWebinars immediately after this webinar that will pop up onto your screen. You'll also receive a survey in an email in the next hour or so. Please take a moment to complete it. Thank you. This now concludes our webinar.